Good morning, everyone. We will be presenting a case about neonatal jaundice. We are Group 11. I am Patrick Durango, and Jenilu Quarisma and Prince J. Estrelon are my colleagues. PM is a 3-day-old female born on March 7, 2022 in Ilocos Sur Provincial Hospital, Gabriela Silang. She is from Pantaydaya, Vigan City. Her religion is Roman Catholic. The patient came for consultation for the first time in our institution, complaining of yellowish discoloration of the body. The date of consultation is on March 10, 2022. The informant is the mother, that means a 90% reliability. The chief complaint is yellowish discoloration of the body. The history of present illness. The baby was born at term at 38 weeks AOG to a gravida 2 para 2 via normal spontaneous vaginal delivery. 2 days prior to consultation, the mother noticed yellowish discoloration of the sclera of the patient's eye with no associated symptoms noted. 1 day prior to consultation, current symptoms are now seen on the face and trunk, thus prompting a consultation. No intervention was given at home. For the review of systems, there is no significant weight loss or gain. The baby is active but not irritable. She has a fair appetite. She calms down with the soothing voice of the mother. She has a good cry. No rashes, no pigmentation. For the HENT, the face is symmetric. No unusual face or deformities. However, there is jaundice or the yellowish discoloration of the face. No ear infections, no strabismus, no conjunctivitis, no nasal discharges, no epistaxis, no oral thrush. There is no cyanosis, has clear breath sounds, no coughing, no wheezing, no difficulty of breathing. For GIT, there is normal bowel movement, no diarrhea, no vomiting, but has yellow-colored stools. No unusual smell, normal yellow urine, no oliguria, no pallor, no bleeding manifestations, no limitation of motion, no tremors, no convulsion. Let's go to the past personal history of the patient. The patient was born 2.9 kg at term, normal delivery, with an Apgar score of 8 to 9. There are no complications during delivery. The patient is purely breastfed. For the developmental or behavioral history, sleeps most of the time and is not irritable. At birth, the baby received BGC and hepatitis B vaccine and there are no adverse reactions. For family history, one older sibling with a history of mild yellowish discoloration of the body was resolved in weeks. There is no history of diabetes, hypertension, allergy, liver disease, and no family history of congenital diseases on both parents. For socioeconomic history, the family lives in their own house, where the mother is 27 years old and the father is 30 years old. Parents are both teachers. Their home is not near any pollutants or any toxic exposure. Their source of water is Nawasa. Source of drinking water is the water refilling station near them. Let's go to the physical examination of the patient. For the general survey, the mouth is moist, and the child looks generally well and is consolable when she cries and not irritable. The vital signs showed a normal heart rate, normal respiratory rate, normal oxygen saturation, but enough febrile temperature. The length is 50 cm, head conference, chest circumference, and the weight are all normal. The head circumference and weight for length percentile showed a normal distribution. The patient is negative from bruising, rashes, cyanosis, and skin turgor. The head is normocephalic with flat anterior fontanelle. For the eyes, there is an ecteric sclera, pink conjunctiva, normal eye symmetry, normal set of auricles, no sinus problems, midline nasal septum, patent nasal passages, no nasal flaring, There is yellow discoloration of the gums, no noted cysts on the tongue or mouth, intact hard palate, no cervical lymphadenopathy for the neck. There are clear breath sounds. For the cardiovascular, there is a normal heart rate, regular rhythm, and no murmur. For the abdomen, there is soft, globular, and no organomegaly. Full pulses, there are no gross deformities, no rashes, no bipedal edema. The salient features: PM is a 3-days-old female, born March 7, 2022, from Pantaydaya Vegan City, a Roman Catholic. Her vital signs are a normal heart rate of 110 beats per minute, a respiratory rate of 32, and a temperature of 36.6 degrees Celsius, and oxygen saturation of 98%. Her birth weight is 2.9 kg, an Apgar score of 8 to 9, born at term of 38 weeks AOG via normal spontaneous vaginal delivery. Her older sibling has a history of mild yellowish discoloration of the body and was resolved in weeks. The symptoms are yellowish discoloration of the skin and sclera, which has a cephalocaudal presentation, and a yellow-colored stools. On the other hand, the signs are there is no significant weight loss or gain, and jaundice. Following the presentation of signs and symptoms, as well as the history and physical examination, the following diagnoses may be considered: the physiologic jaundice, the pathologic jaundice, the breastfeeding jaundice, and the breast milk jaundice. In the table, it is shown that the physiologic jaundice has an onset of more than 24 hours to 72 hours or 3 days. It has a duration of 7 to 10 days, and the type of bilirubin is primarily unconjugated, and it is due to physiological alteration in neonatal bilirubin metabolism. While pathologic jaundice has an onset of less than 24 hours but can go on to more than 2 weeks. Both unconjugated or conjugated bilirubin are seen, and it is due to impaired hepatobiliary function. The breastfeeding jaundice can be seen on the 3rd to 5th days of life. It can go on to a week, and unconjugated bilirubin can be seen primarily. It is due to inadequate intake of breast milk, leading to dehydration and an increased enterohepatic circulation, also called starvation jaundice. And the breast milk jaundice has an onset of 1st to 2nd weeks of life and can go on up to 3 weeks. Unconjugated bilirubin are primarily seen, and it is due to inhibition of the UGT enzyme pregnanidiol and the conjugation of conjugated bilirubin in the intestines by beta-glucuronidase present in breast milk. Pertinent sign of jaundice: did it occur less than 24 hours? If yes, it must be pathologic, and if no, is it well fed or poorly fed? If it is poorly fed, it could be breastfeeding jaundice. And if well fed, did it occur in the first 3 days of life? And if no, it could be breast milk jaundice. And if yes, it could be physiologic jaundice, and the patient must be clinically well. Our final diagnosis is physiologic jaundice. What is the pathophysiology of physiologic jaundice? The neonatal physiologic jaundice results from simultaneous occurrence of the following two phenomena. The bilirubin production is elevated because of increased breakdown of fetal erythrocytes. This is the result of the shortened lifespan of fetal erythrocytes and the higher erythrocyte mass in neonates. The hepatic excretory capacity is low in both because of low concentrations of the binding protein ligandin in the hepatocytes and because of low activity of glucuronil transferase, the enzyme responsible for binding bilirubin to glucuronic acid, thus making bilirubin water soluble or conjugation. And that would be all. Thank you for listening.